So good evening. My name is Colleen Marr, and I will be your instructor tonight, and I will be talking about orthotics or splinting, you might hear it referred to, and we're going to begin this presentation. So it's important for the exam that you know your terminology, that you may hear or see a question that uses the words orthotic or splint, okay? Because the terms have changed. They're more focused now on orthosis. However, in your textbooks, they still use the word splints in some of the chapters. So you may see that in a question. Just know it means the same thing, orthosis or splint. I list the purposes here, and I'm going to go through those in a little more detail. But when we talk about why do we make an orthosis, we do it for multiple reasons. And I'm going to get more specific, but I'm just going to read these through: to rest structures, to prevent deformities, to increase joint range of motion, to protect a structure, to increase function, to decrease pain, and to restrict range of motion. So we're going to talk about those in just a little bit here as we go through here. So you need to make sure when you're studying for the exam that you review all the basics of orthotic fabrication. So go through the basics of that. Very, very important. And you need to know the different types of orthoses or splints and the purpose for them. So I have the 4 top types listed here. The first one is static. When I think of a static splint, that is or a static orthosis. That is an orthosis that has no moving parts. So you can see in this picture here, this is an example of a static orthosis. It's a hand-based thumb orthosis. And there are no moving parts. Why we make static orthotics is because we often want to put a structure at rest that might be inflamed, such as somebody who has CMC arthritis. They have pain, it's inflamed, and so we make them. For example, this type of a splint, a hand-based thumb splint, to put that CMC joint at rest. We also make static splints to support different structures. So a structure that might be unstable. And sometimes we will make static orthotics to protect a structure. Sometimes a person will have a fracture and the doctor takes them out of the cast a little bit early, and they want the therapist to make them an orthotic to protect the bone until it's thoroughly healed. But you can easily remove it then to do your exercises and stuff. And also a static orthosis is used to immobilize structures. So sometimes a doctor will write an order that just states, immobilize this joint, and we make a static splint to completely immobilize, or a static orthosis to completely immobilize it. Now, the second type that is listed there is a dynamic orthosis. This is an orthosis that has moving parts. It might be elastic bands, rubber bands, or springs. And the focus, when I think a dynamic orthosis, I think I would use this type of an orthosis for someone that I wanted to increase their passive range of motion or to augment active range of motion. So when I think about a dynamic splint, it might be somebody who, let's say they have a PIP joint flexion contracture, and I want to try to improve the passive range of motion to passively get it into full extension. I would use a dynamic PIP extension splint, okay, to help move that. So when I think dynamic splints, I often think about this is a splint or an orthosis that I would use to improve passive range of motion. I would also use, though, a dynamic orthosis to augment active range of motion. So, for example, somebody who has like a radial nerve palsy and they have a dropped wrist and dropped MCP joints, I would make a dynamic extension splint or orthosis that has rubber band traction that would pull the fingers and wrist up into extension, but would allow the person to actively flex their fingers. And when they relax, the rubber bands pull them up into extension, just like I'm demonstrating. So they would have, if they had a radial nerve palsy, they would have a dynamic extension splint or orthosis that would bring them up using rubber bands or elastic traction to pull them up into extension. And then it would still allow them to use the muscles that are working, their flexors, to grip onto something. And when they relax, the rubber bands or the elastic would act as the tendons to pull them up into extension. So when I think of dynamic splints, I often think of increasing passive range of motion and augmenting active range of motion. So when you are taking the exam, you must keep thinking about, okay, what is the purpose? What are they saying? So that I make sure I select the right orthosis in this question. So know these different purposes. Now, the next one that is listed there is serial static orthosis. And this is using either casting material or regular orthotic material to make serial adjustments to the orthosis to increase range. So it might be somebody who has a contracture, let's just say at the wrist, and you start to bring them up. You make an orthosis that brings them up into a little bit of extension. You don't want to overstress those structures, but you want to put some tension on them. You bring it up, and then you give them a home program, you work with them, and then you check their motion a couple days later and you see, oh, okay, they can easily get to this position now. I'm going to bring that splint back a little bit more. And so every couple days you take and you make these adjustments to increase the range of motion. So, and then the last one that is listed there is static progressive orthosis. And that is, they use a static adjustment part, such as like they'll use a hinge or a turnbuckle or some kind of a strap to increase tension and motion. So I used to use these, and a lot of these, I have to say, some of the better ones are the ones that are commercial brands. And so if you have somebody who might have limited, say, supination, we might make them a static progressive orthosis, or we would purchase one in which there would be a strap that you would slowly keep increasing the tension to increase the amount of motion, the amount of supination. So those are the four major types of orthotics that you should be familiar with, and you need to know the purpose of each one of those. So again, static, no moving parts. Dynamic, there's moving parts. I always think of increasing passive range of motion and also augmenting active range of motion. Serial static is for somebody who really has a contracture and you want to slowly increase the motion without causing a lot of trauma to the structures. And then static progressive also, again, helps to increase motion. Now, the exam, an important part about the exam is safety, okay, being safe. And when I think about making an orthosis, it is absolutely critical that you're safe in the way that you do it. So I have some tips here about keeping it safe. The first thing, if you have a question on the exam about, what kind of an orthosis you should select, see if there's anything in that question that says that the MD ordered a certain type of orthosis, or that they want you to focus on putting the structure at rest, or they want you to increase passive range of motion. But follow specifically in that question. If it has anything about what the MD orders, that's what we make, okay? So that's what you would want to select as an answer. Performing skin checks. Okay, they might have something on there about, safety from a skin check perspective. So one thing that you always want to do is before you make an orthosis, we always want to check the person's skin before and then after you make the splint. And if you can, during, you're going to be checking that. As soon as I take the material off, I'm going to check that person's skin to make sure it's okay. Because some people have fragile skin, and you want to be very careful with using hot material on their skin. So first you want to check their skin to make sure there's no issues before you start to make the orthosis. You always want to protect the skin with stockinette when you can. And so that's really important, is that, how do we protect and keep this person safe when we're making an orthosis? Well, one thing that we do is we'll do a skin check to make sure that there's no issues before we make the orthosis. We'll use a stockinette to protect their skin. And the other thing that we want to do is, once we heat the material up, we want to take and check it on our own skin to make sure we can tolerate. But there's just a few seconds that you have to work with it. So you have to move on it. But at the same time, you want to be very cautious about the temperature of the material. You also want to be careful of our bony prominences. And one of the main areas is this ulnar head or ulnar styloid that sticks out here, that can often become irritated if the orthotic material is hitting up against it. So you want to be careful of that. They might have a question on there that the person that you fabricated a wrist orthosis for someone, and they return the next session and they have redness around the ulnar styloid. What would you do? Well, you would modify it. You would heat it up and you would adjust it. We don't like to give our patients moleskin to let them put it in there, because sometimes they can put moleskin in and it can actually make the situation worse. If there's part of your patient education after you make an orthosis is to, educate them on the importance of contacting you if there's any kind of problem with the orthosis. Do not impinge upon creases of the hand. So going into the certification exam, you need to be familiar with your creases and what orthoses are really important that you watch the creases. So when I think of a volar wrist orthosis, I think that this is one that you want to make sure that your distal palmar crease, like I'm pointing to here, is clear, and your thenar crease is clear. That way, they'll get the support for their wrist, but they'll also be able to use their hand, their fingers, while they're wearing it. So knowing your crease is going to be very, very important. When I make a mallet finger orthosis, which is just to keep the DIP joint extended, I want to make sure my PIP joint crease is free. So be aware of your creases when you are making your different orthotics and when they ask you questions, because if you find it, they may give you a question that says you fabricated a wrist orthosis for somebody, but the person is complaining that they're having difficulty using their hand. One thing that I would look at is this orthosis blocking their creases? Okay. Use a pattern. Okay. You don't want to just eyeball and make an orthosis. We use patterns, and that's what makes our orthoses very unique and to that person, because you can buy commercial brand orthotics, and you can go to CVS or any of these different kinds of pharmacy stores, and they have a lot of those. But the ones that we make are specific to that person. And we do that by making a pattern first and making sure the pattern fits the way that it should. And then we go ahead and trace that on the material. Monitor water temperature and make sure, again, once you put the material in the hot water, that when that comes out of the hot water, that you dry that material off. We never put a splint that's hot on a person that has water on it, okay? Because it's the hot water that can actually burn somebody. So you want to make sure that you thoroughly dry the material. We pat it dry. You want to make sure, if they ask any questions, know your mechanical principles of splinting, okay? So if we want to decrease pressure, we want a wider splint. So for example, if I was making a wrist orthosis, I want it wide enough that it goes from the side of my forearm here on the ulnar side to the side of my forearm on the radial side. I just don't want it to come down and be very narrow going down the whole forearm. I want it wider, and it should go 2/3 down the forearm, and you always want to make sure that you round your edges, okay? If you have a question on a dynamic splint, most important is remember, we use a 90-degree angle whenever we're making a dynamic splint. So you want your outrigger so that you're able to put a sling that's at a 90-degree angle. And so, for example, okay, they might ask something like this, but for example, if I had, let's say I'll do on my pinky finger here, if my MCP joint was down in a flex position, okay, and I wanted to get it up into extension, my outrigger, and if I had a restriction, my outrigger should come right down at this 90-degree angle here on my finger. It should come straight down. You don't want it back like this. You don't want it like this. The outrigger should be right over the part. So if I have a restriction of my MCP joint, that outrigger and that sling is going to come just distal to that joint that I'm trying to work on. So it would be a 90-degree angle to the proximal phalanx, okay? If it was a PIP joint contracture, it would be a 90-degree angle to the middle phalanx, so just distal to the joint that is restricted. So that's a very, very important thing for you to make sure that you keep in mind when you're taking the exam. The other really super important mechanical principle is low load, prolonged stretch. So what that means is this: how do we know how much tension to add to the elastic band or to the rubber band? What you want to know is the basics is that we want a low load. We don't want it to be a real strong tension on that joint. So we want a low load so that they can tolerate a prolonged stretch. Okay, if you make it too tight, too much tension on that elastic band, they're not going to be able to tolerate the splint for long or the orthosis for long. So you want it to have a low load with a prolonged stretch. The other thing is, on the exam, watch, a big part of when we make an orthosis is to make sure we educate that person in wear and care, okay? And so you want to ensure that the person understands donning and doffing that orthosis. In my 35 years of experience, there was 1 or 2 times that I made an orthosis and I got to the end of it and the person could not don it. They could not put it on. And so you have to figure out, how do you manage something like this? Is there a family member that can come in? Because you can write the instructions down, but you don't want to give an orthosis to somebody who can't don it properly. It could cause more problems. So those are the kind of things that you're going to want to keep in mind as you're taking the exam. The other thing in regards to keeping it safe, just keep in mind, as we get older, our skin is a little more fragile. It's thinner. And so for us, as we get older, when you put hot material on it, we could easily burn. So that's, sometimes what you might want to do, and this is your clinical reasoning, is you might want to take and put an extra layer of stockinette. Make sure that material's dry. Make sure you can tolerate it on your own skin before you put it on somebody who has fragile skin. Orthotics are made for children and infants, but again, they can't come out and say, oh, that's too hot, infants and younger children. So you need to be especially very cautious with them. And they do have stockinette for children that is really can fit over their small little arms, but you have to be very, very careful. Post-surgical patients, you want to be very cautious about their surgical site. So if you can fabricated on the opposite side, that is ideal, but you want to speak to the surgeon to see if there's a reason why they want them on, they want the orthosis on the side of the surgery. Most common, we try to do it on the opposite side. And then sensory impairment. You will be probably making an orthosis for somebody who has a sensory impairment. Now, in regards to like physical agent modalities, hot packs, cold packs, we do not use those on people who have sensory impairment. But there are times that a person has like a nerve laceration that we have to put them in a protective splint. So you just need to be very mindful of the fact that this person may have a complete sensory loss. And then fractures. Okay, sometimes we're asked to make what they call a fracture brace or fracture orthosis, and that is to immobilize that bone until it heals. Sometimes a person will be put into a cast and they'll take them out of the cast early, but the doctor will order an orthosis to protect the bone while it's still healing, but they want the person to be able to take it off to be able to exercise. Now, clinical decision making is also important on the exam, like to really think about, what is this question really asking? And so again, I can't emphasize enough to not only know the different types of orthotics, but also the purpose of each one of them. But I want to go over some of this clinical decision making. The first one is procedural reasoning, and that is, following treatment protocols and how an orthosis might fit in. So following different protocols and knowing the evidence that backs up your selection. So for example, when I think about carpal tunnel syndrome, there's been some studies out there on a lot of studies on carpal tunnel syndrome, but in regards to an orthosis, what they say is a wrist splint in the neutral position is the best position for carpal canal pressure. So this is knowing some of your evidence for the most common orthotics that you should know as entry-level therapists. And also too, on the exam, know that there are going to be, there might be a question there where they present with a situation in which it's a complicated condition, with a complex condition with, an orthosis that might be complicated for a new therapist to make. Know that it's okay to consult with a service competent OT, or maybe this is somebody that you have to refer to an OT who is specializes in hand therapy. So know the importance and how it's okay to consult with somebody who is more of an expert in it, or just to refer that patient to them to make the orthosis if you don't feel comfortable with it. And when I think about certain conditions, you'll get people who have, transplants, nerve repairs and stuff. And as new therapists, you really aren't going to feel comfortable going out there treating those. So you need to know that on the exam, if they ask a question like that, that ideal is to consult with somebody who is an expert in that area. Now, conditional reasoning is knowing about the injury or condition that you are making the orthosis for. So that's going to be important. Now, in our textbook, okay, in chapter 6, we go over a lot of the more common hand conditions that as entry-level therapists you should be aware of. So go through those, because not only do we in chapter 11 have the section on orthotics, but we also in chapter 6, we have different hand conditions. And within each of those conditions, we talk about what would be the most common orthosis and why you might give that to the person. And we also do that in chapter 11. In chapter 11, I have a list of different diagnoses and what are the most common orthotics you would give them and why. So not only the condition and the type of orthotic, but the reason why. What is the purpose of why you're giving them that? So know your injury or condition, and be aware too of that. If when you're reading about the different hand conditions, is there any condition in which there might be a change in the kind of orthosis that you might give them? So when I think about that, we see that with nerve injuries. We see that with some tendon injuries. So be aware of that. Interactive reasoning is when we're making our orthotics on our patients, you have to build a rapport with that person and their caregiver to collaborate on the best type of splint or orthosis. And sometimes a doctor will write an order for a certain orthosis. And when you're talking with the patient, they say, I'm not going to wear that. You can make it, but I'm not going to wear that. That's when you need to contact the doctor and say, listen, this is what the patient reported to me. Is there a possibility we could try this type of an orthosis with this then during the day when they're out in public? Because the bottom line is you want to keep it client-centered. You want to make an orthosis that the patient is going to wear. The last thing you want to do is make an orthosis and the patient tells you they're not going to wear it. Okay. So sometimes, we're presented with situations where a patient will say that. I used to have a lot of young people who had rheumatoid arthritis, had deformities, and they were referred for different kinds of orthotics. And when I showed them what I was going to fabricate and how I was going to make it, some of them would say, I'm not going to wear that out in public. So I had to bargain with them sometimes and say, okay, how about if we do this? How about if I make it and behind closed doors, you wear it because this orthosis is what's going to really help to realign your joints. But during the day, let me call the doctor if we could get this commercial brand that is not as obvious. And it was for aesthetic reasons. This person that I'm talking about right now did not want people seeing her hand in all these different types of splints. So, just keep it client-centered. Think about in the question, if there's anything in that question that talks about what the client wants in regards to the splint. Now, you always have to follow the doctor's orders. But if you have a patient who says, I'm not going to wear that, you need to figure out how you can make this work for everybody. So we work as a team, that's for sure. Pragmatic reasoning. Pragmatic reasoning is consider the timing. So you might get a question on the exam that says, it's Friday afternoon at 4:30, and the doctor is sending a patient over for a flexor tendon splint. What would be your best approach, knowing that your department's going to close in 15 minutes? They may give you something like that. So you need to think about what are all the possible options there that you can do. So timing is a big deal. Characteristics of the setting. Keep in mind that some therapists make their orthotics in the person's home. So during home care session. So they don't have the big fancy splinting pans and all the materials and stuff. So look at the situation that they're giving you in the scenario and try to make the best choice based on everything, considering the time of the day, the characteristics of the setting. Consider the service competence of the therapist. How competent is this therapist to make that orthosis? And again, it's okay if you decide like, I don't feel comfortable with this. I'm either going to do it side by side with an experienced therapist, or if there isn't one there, I'm going to refer this person to a hand therapist, and that's okay. Now, a couple of other things that I wanted to point out is the resting hand orthosis, or sometimes you'll hear it interchangeably used as the functional hand orthosis. Now, if you look at the numbers there, I will tell you that they vary in the textbooks. And every time I do a different chapter in a textbook, these numbers are changing. But this is a resting hand splint. So what they're saying is 0 to 20 degrees at wrist extension. The MCPs are slightly flexed, 20 to 30 degrees, and the IPs are slightly flexed. And the thumb is slightly extended in an abducted position. And sometimes they'll refer to it as opposition. So this is a resting hand orthosis or functional hand orthosis. You're going to see that, and you're going to see these numbers vary. So don't get caught up in trying to memorize numbers so much as getting to know what that position looks like, okay? Take your hand and position it so that when you get a question on the exam, you're going to be able to figure out which one it is. So the wrist is, slightly extended, the MPs are slightly flexed, the IPs are slightly flexed, and the thumb is in slight abduction and extension. And sometimes they'll say opposition, which is this position here. Now, the other orthosis that you need to be aware of is what we call the safe position orthosis. Sometimes they'll refer to it as a functional orthosis in the safe position. So know it both ways. It also may be referred to as an intrinsic plus or anti-deformity splint. And it's used to maintain the length of your collateral ligaments. So in the safe position, and I encourage you all to do this with me, is to take in, the wrist is extended 15 to 30 degrees. Now you have to be careful. 30 degrees is pretty high. And so you want to be cautious about going that high in wrist extension. But I put that there because that's what some of the textbooks state. But I probably myself would go more like about 15, 20 degrees. The big thing is your MCPs are flexed. They're flexed 50 to 70. And again, sometimes I have seen this number even greater, okay, depending on the textbook. And the IP joints, that's your PIP and your DIP joints, they're in full extension, and your thumb is in what we call palmar abduction. And again, this is also called the position of opposition. It looks like this. So when I look at this, again, they call this the intrinsic plus. Think about this as your intrinsic muscles do this position, but you need to get the wrist back, okay, and a little bit of extension. The MCPs are flexed, the IP joints are extended, and the thumb is in palmar abduction. So you need to be aware of that. And the reason we do that is to maintain the length of the collateral ligaments at each of these joints, at your MCPs, your PIPs, and your DIP joints. Very, very important to know. And in your book, I believe it's chapter 6, we talk about burns, and you need to know that chart on burns and the different anti-deformity positions, okay? And in that, they talk about a burn to the dorsal aspect of the wrist and the hand, and we put them in a functional splint in the safe position, okay? So go to that chart and know all the different anti-deformity positions that are recommended there, but this is the safe position. Now, other reasons why I might use a safe position is often the doctor will order it if somebody has like some kind of an infection. Like I used to get people with dog bite and cat bite wounds, and the doctor, while their hand was so swollen and stuff, the doctor wanted their hand positioned so that we could preserve the length of the collateral ligaments so that once they can come out and start moving, they'd be able to move normally. If we would let them swell up in full extension, they're not going to be able to make a fist. They're going to have big problems. So we take and we put them in this safe position. So for the exam, I just want to make sure that you're really familiar with the resting hand orthosis and that you're familiar with the safe position. Now, I wanted to just touch on some of these common orthoses. These are for arthritis. And so this is just a resting hand orthosis. And when I think about the resting hand orthosis, I think of somebody who does have arthritis who might have a flare-up. We would put the whole, if they have a flare-up where it's affecting the wrist and the hand, I'm going to put them in a resting hand splint to put those structures at rest while they're having this flare-up. So that's a resting hand splint. Now, if the person just has arthritis in their wrist, there is no reason to immobilize the fingers. So I would just put them in a wrist splint, okay, or a wrist orthosis that immobilizes the wrist but leaves the fingers free. So you have to look at one, what the doctor is ordering, what the client is telling you. What are they telling you about where they're having most of their discomfort? So in that case, if it's the whole wrist and hand, I'm going to put them in a resting hand splint to put all those structures at rest while they're having a flare up. If again, if it's just specific to the wrist, then I'm going to just make a wrist splint. If they have osteoarthritis and they're having severe pain in their thumb, usually it's the CMC joint, I'm going to make a hand-based thumb splint. Now, some of your doctors will order a forearm-based thumb splint. So you have to see what the doctor likes. Each doctor is very specific about what they like, but they looked at both, and the hand-based thumb splints are just as effective as a forearm-based thumb splint. But again, it's the doctor and what they order and what they want and what has worked for their clients. But again, I don't have to mobilize the whole wrist and hand. If you don't have to immobilize certain joints, you don't want to immobilize them. Only immobilize what has to be immobilized. The photo in the middle here is just one of many different types of ulnar deviation splints. So it's to prevent the person from going into ulnar deviation. So it takes them and it keeps their joints aligned so that the MCP joints are aligned the right way, and so that you have the extensor, the EDC going right over the MCP joints and not dropping over. So this is just one example. There are many different types of ulnar drift splints that you can make, anti-ulnar drift splints that you can make, and that are also available commercially. And then I have a picture here too of a silver ring. I personally absolutely love these for people who have like boutonniere and swan neck deformities. I have found them to be very, very effective, and people don't mind wearing them because they look nice and they do the trick. And then there is on this last picture here, where you see the rubber band traction. This is a dynamic extension splint for somebody who had really severe ulnar drift and their MCP joints subluxed. And so they went in and they put they replaced their MCP joints. And so when they do, after they come out of having their joints replaced, they have to go into a dynamic extension splint. And so this is a dynamic extension splint that we made. And I don't know if you can see this outrigger here on the side, but this is an additional outrigger that has pulleys that then slings that then pulls these two digits, the index and the middle finger, towards the radial side too, to get them to move in the opposite direction of what they've been so used to moving in. And what's nice is the rubber bands hold them up into extension, but the person, as you can see in there, is able to flex their hand, okay? And then when that person relaxes, it brings their fingers back up into extension. And so these are some common orthoses for arthritis. This next slide is common orthoses for people who have flexor and extensor tendon repairs. And so important for you is these are more complicated injuries, but they're probably going to ask you questions, especially the OTs, on what type of an orthosis would you fabricate for somebody who has a zone 2 flexor tendon injury? And that's what you see in here. This is just one example. There are many different types of protocols out there for flexor tendons, but the bottom line, that the big take-home message for this is, know that when it is like a zone 2 flexor tendon, such as in these two cases here, we always make a dorsal protection splint. So this rubber band traction is following the Kleiner protocol, but there's different protocols out there that don't use rubber band traction. But what they all do use is the dorsal protection splint, this dorsal blocking splint, because what it does is it protects the wrist and hand from going up into full extension, because the surgeon just repaired the flexor tendons. And the last thing you want is for that person to go up and go into full extension. Now, there are different early mobilization protocols that I talk about in chapter 6 that you can take a look at. But I would just really make sure that I know the basics about the tendon repairs, and that I know that if there's a question about, zone 2, that one of the first things I would think of is a dorsal blocking splint. This is one of the more common extensor tendon injuries. It's a mallet finger, and it looks like a simple splint, but let me tell you something. Sometimes it can be very difficult, especially if the person just had surgery. So sometimes we make it when a person doesn't have surgery, and sometimes we make it after they've had surgery. And so the important thing is that it extends the DIP joint. They have to wear it for 6 weeks. Okay, cannot take it off, can't try it out, flexing their fingers. If they have to take their orthosis off their finger, they need to lay their hand flat on the table and just pull it off. And they can check under their finger to make sure the skin's okay, then put it right back on. But what's important about this orthosis is that it immobilizes the DIP joint in extension, but allows flexion at the PIP joint. So you can see that right here. So it allows flexion at the PIP joint. Okay, 1 second here.